welcome back everybody from the break. We're going to begin with our session 3 for this training, but before we begin that, and I hand it off to Yayoh, I just wanted to let everybody know again about the handouts. If you are having issues, I think there's some issues with downloading the second handout. That information and documents, they are posted on Connect. So if you are having any issues, please log on to Connect and download that. If you do not have access to Connect, please send us your email and we'll try to send you that in real time so that as we go through this session 3, you'll have that document to refer to. So without further ado, I'll turn it over to Yayoh so that she can kick us off with session 3.
Thank you, Angelica. Good afternoon, everyone. My name is Yayoh, and I'll be going over session 3. So the session objectives will be to discuss key care transformation concepts in all phases of the patient's journey, which includes the workflow, the data sets during each transition of care, empanelment and access, risk stratification, telehealth encounters, longitudinal care management assessment, self-management support, transitional care management, and advanced care planning. So as most of you already do, you're having some patient encounters with your patients prior to the patient's virtual or office visit. So we'd like for you to continue to ensure that your patients have options to access the care team, such as providing same-day access or next-day access, telephone advice on clinical issues, after-hour service, direct messaging through patient portal, secure and encrypted emails, and on-call scheduling. So most of us already have remote access to the EMR, which definitely helps. So for the alternative care visits, due to the COVID-19 pandemic, most of you, if not all of you, are now providing telemedicine visits in addition to telephone visits and e-visits. So this has definitely helped with patient access, and the state has shared a number of resources available to you for telemedicine. So for more resources on telemedicine options, including free options, you can go ahead and visit the link at the bottom of the slide. So we discussed providing 24/7 access and alternative care visit options for your patients. Again, anyone on the care team can interact with the patient and for various reasons. So either to remind them of their appointment or follow up on any needs that the patient may have. So you want to try to continue to schedule your patient's telemedicine encounters with their empaneled care team members. And now with COVID-19 pandemic, you want to conduct screening calls for as much of your high-risk patients as you can. And to learn more about the COVID-19, the front desk triage workflow, their practice process maps, and phone scripts, you can access those resources in this box, in the green box on the slide. And lastly, we also want to keep in mind the patient's experience. So just a quick refresher on the patient empanelment process. First, you want to identify your active patients by using a look-back period. For an example, you want to do a 24-month look-back period. Secondly, you then want to empanel your patients to the practitioner or care team member based on your empanelment criteria. You want to remember to do a panel review periodically, like every quarter with staff changes, and you want to keep your patient panel active. And lastly, you want to measure and optimize continuity. So for an example, using a provider-centric method, which you can do at least semi-annually. So as I said earlier, you want to keep continuity in mind as you schedule your patient appointment with their empaneled physician or care team member. So due to COVID-19, most of you have updated appointment scheduling protocols. And you want to make sure that they include how you identify symptoms for telemedicine versus in-office visits, and the time of day that you schedule your patient for an office visit. And you want to base those based off of the presenting complaints. So you also want to help patients ahead of appointments to set up for the telemedicine visit, and doing this will help reduce your no-show rates. So just a quick refresher on the two-step risk stratification process. Since you're all familiar with this concept now, with the algorithm risk stratification step, you already get the HCC score with your quarterly attribution list. The CRIS pre-AH tool also applies some algorithms to the monthly avoidable hospitalization reports you all use. For reference on using the CRIS risk stratification tools, you can check those out on these links in this green box right here. You also want to continue working with your CTOs and practice coaches on incorporating application of these tools in your workflows. And remember to apply your clinical intuition to determine the final risk score for your patient. As we know, doing this includes using your knowledge of your patient's social needs, their health literacy, their activation level, their family or caregiver support. And again, this can be revisited periodically. And this figure located on the slide just shows step 1 and step 2 of risk stratification. It's basically just depicting that they occur simultaneously over time and they're independent of each other and the cycle goes on. So we have a poll. If you can just choose a response, how often do you use the CRIS tools for risk stratification of your at-risk or high-risk patients? Do you rarely use them, sometimes, or regularly?
We'll give it about 10 more seconds before we close the poll. For those that haven't clicked their answer yet, just click on the screen to the answer that you have for the question that's listed on the poll.
Okay, thank you, Angelica. So for we see that 73% of the voters regularly use the CRIS tool, and that's awesome. So for those of you who use it regularly, we want to tell you great work, and we hope that you find it helpful. If you have any feedback on using the tool, feel free to share your feedback with your practice coaches and connect with your colleagues so you can learn more, so they can learn more from you. And for those of you who use the pre-AH tool, sometimes or rarely, please feel free to review the recorded webinars on the links in the previous slides. And you can also reach out to your CTO or practice coaches to support you on how to incorporate using these tools in your workflows. Okay, so last year we discussed care team huddles, and I just want to do a quick refresher on this. Just remember that it's evidence-based tool used by the primary care team. They should occur daily. They should have an agenda. They should be less than 10 minutes, and they should discuss or call out all care needs. And on the upcoming slide, we're going to show you a Huddle video. Again, this is just a reminder from last year's training.
Are you ladies ready to huddle?
Yeah.
Okay.
Some add-in spots for the day. We could do a 9:30, 11:30, a 2:15, and a 3:30.
That looks great.
And then I will have our scheduler call the 2 o'clock since Ted chronically misses his appointments.
Okay, thank you.
Okay, our first patient of the day is Sue. She's coming in for an ER follow-up. She was seen within a different system, so we will have to get those records pulled for her.
Okay.
And that A1C that we added onto Mary's labs came back, and her result came back to a 7, so we could do some warm handoff to the RN for some diabetes education.
Okay, great. Give them a heads up about that.
Okay, Jane, she's coming in for some lower back pain. Then we can see if the physical therapist can see her if she's eligible.
Okay.
And then we have Ed coming in. He doesn't have any insurance, so we could possibly do a referral to case management.
Okay, and if she's available, we'll make that a warm handoff.
Okay.
Okay, our last one of the day, Bob, he's coming in for his Medicare visit. He is a candidate for CCM, so we can see if he wants to set that up today. He is our last patient of the day, so we can probably start to see our patients now.
All right, great. And you're going to get that Huddle handoff sheet ready for everyone?
Yep, I'll get one to the RN and the scheduler.
All right, thank you.
Morning, ladies.
Good morning.
All right, here's a Huddle handoff form for each of you. On here, we have some spots where you can do some add-ins. And then Sharon, if you could call our 2 o'clock Ted, just because he tends to miss his appointments. And then Teresa, we have our 8 o'clock patient. They're going to be a new diabetic, so if you could do some education at the end of the visit. All right, sounds
Great,
good.
thank you.
Thanks. Paige, do you want to go ahead and start visit prep, and I'll go in and do in basket?
Yeah.
Dr. Rachel, I was viewing results, and Mary's glucose came back elevated at 120. I'm going to go ahead and add an A1C.
Oh, perfect. Thank you.
Okay. Looking at our chart prep for the day, Joe is coming in. The only thing it looks like he's due for is his colonoscopy, so we will get that ordered for him today.
Great, and go ahead and schedule it right away too, please.
Bobby Joe's PAP came back normal, so I'll go ahead and message her through the online portal.
Thank you. And Paige, I noticed that Lisa's TSH came back a little bit high. Would you mind sending her a message through the portal that I'd like to increase her levothyroxine to 100 micrograms once a day and repeat that TSH in about 4 to 6 weeks?
All right. We will get that levothyroxine sent over to her pharmacy. I'll get the order put in for that TSH, and we'll message that all to her on the portal.
Thank you.
And on Kathy, we received a prior authorization paperwork for her Vibrid. I called the pharmacy already, and they will do sertraline. Do you want to go ahead and order the sertraline?
She actually failed sertraline, so if you don't mind doing the prior authorization, I'd appreciate that.
Okay, I will do that.
Thank you.
Excuse me, Dr. Rachel, you have a moment?
Yeah.
I have a patient of yours on the phone, Sarah. She's been sick with cough, chest congestion, about 10 days. I was tried over-the-counter medication, not getting better. Now it seems to be settling more in where she's having a hard time catching a deep breath. I'm wondering if you can see her at all today?
I think all of my double booking spots are filled up. Maybe we can check with Eric.
Okay.
Eric, would you have room to fit a patient in your schedule today?
Yeah, I should have room later this afternoon. Is it a patient I've met before?
Yeah, her name is Sarah. You've seen her in the past.
Okay, yeah, I think I know who that is.
Okay.
What time would work for you?
About 2. I should
Okay.
have an opening at 2. If you can put that in my schedule, that'd be
Perfect.
great.
I will. Thank you.
Okay.
You're
Thanks.
welcome. Also, Dr. Rachel, I have a patient later this afternoon who kind of non-compliant diabetic, having trouble managing her sugars. Would you mind helping me later this afternoon with her?
Sure. Let me know when you want me to pop in the room and we can take a look at her together.
Perfect.
I also have a patient that I'd like to bring you in on later. It's a well-controlled diabetic, and I'd just like to introduce you to the patient and maybe have you do their next follow-up so that if I'm ever out of town, they're comfortable with you taking
Absolutely.
care of them.
Absolutely.
Okay.
Thank you.
Thanks.
Thank you. So hopefully that video was a good refresher on just the team huddles and what it usually consists of. So with this slide right here, this shows the team huddle checklist, and you should have it in your handout packet. We'd like that you use it as an example of how to set your agenda for your team huddles. So you always want to start by checking in with the team. You want to identify scheduling adjustments. You then want to make sure you determine the patient care gaps that you have and what follow-ups are needed. And we're gonna take a look at a slide showing you the template that you can use for follow-ups. You wanna discuss any important reminders for the practice, and also don't forget to close on a positive note, you know, giving team members shout outs and thanking everyone for being there. So this template is also in your handout packet, and it helps to summarize patient care gaps. If you look at it, it talks about screening, immunization needs based on confirmed appointments or when their last follow-up was. So this is a template that you can use for that. So during COVID-19, very few patients are seen at the practice site. However, the care team members should maintain the CDC guidelines for social distancing in the workplace, such as keeping 6 feet distance between the care team members where possible, and putting on some form of PPE. So we have links right here that shows you where requests for PPEs can be routed. They can be routed through your local health department. So look at the links right here for the request forms. And also, as a safe practice, most patient prep checkings are now done virtually. So initial screenings can be done virtually, and pre-set up activities to support the PCP can also be done virtually. So additional things that we want to just emphasize is you want to let your patients know that you're there to support their medical needs. You want to encourage your patients to have their caregivers maintain distances from others and frequently wash their hands. You want to, have your patient, let them know that they should maintain a 2-week supply of food and medication, and to move around while they're home and exercise, rest often, and stay connected virtually with friends and family. We also have included additional resources for links to flyers that you can post in your waiting rooms. And these resources are from the CDC and patient flyers from the MDPCP program that you can send to your patients. So now with virtual visits, you can still complete much of the rooming activities virtually with the patient before the PCP telemedicine visit. So you can complete activities such as medication reviews, allergies, patient history, and just the activities highlighted inside of this red box right here. You can record the patient's self-reported vitals as well if they have a self-monitoring device or a DME at home. And then other pre-consult visit activities that can be done, such as screening for behavioral health and initiating the annual wellness visit. So you want to be sure that you review the key ECQMs for your diabetic and hypertensive patients, and you want to identify when a test is due. And for a refresher on the behavioral health screening and expert, you can visit these links located in the green box at the bottom of the slide. Okay, so almost all PCPs now conduct telemedicine visits, but we want to keep in mind that this focus is still on the patient's health concern. It's still on medication management, the patient's risk level. We're still testing orders. We're still running tests and running orders and providing necessary referrals and finalizing on the annual wellness visits. So we want to remember the importance of the annual wellness visit it's one of the key factors that determine the MDPCP beneficiary attribution to your practice. And again, you can go to this link located at the bottom of the slide to learn more and get ideas on how you can improve your workflow. So here's a list of telemedicine resources available to you. And to download the list, use the link in the box right here. And you can also see more resources on telemedicine in these links. So we'd like to have you watch a video. And as you watch the video, just take the time to observe how the MA does a warm handoff to the PCP in a regular office visit. And just think of how this can be similarly done in a virtual setting.
Engaging patients and their families can improve patient safety in the primary care environment. One way to do this is through the use of a warm handoff. A warm handoff is a handoff conducted in person between two members of the healthcare team in front of the patient and family or caregiver. A warm handoff is similar in concept to nurse bedside shift report and engages the patient as a member of the team so that he or she can speak up, ask questions, and clarify information.
Hey, John, how you doing?
I'm doing all right, Doc.
Mr. Winston is now a proud grandpa.
Oh, that's right. How's your son's family doing? I bet it's exciting having a new grandbaby in the family.
Oh, yeah, it is. They're doing great. Thanks for asking. By the way, this is my daughter, Sue. She helps me with my medical stuff.
Welcome, Sue. Nice to meet you. So, let's have your report, Amelia.
Well, Mr. Winston said he experienced an episode of rapid heartbeat while he was working at home 2 nights ago. When his heartbeat wouldn't slow down, he went to the emergency room and they kept him overnight for additional testing and observation. They diagnosed him with atrial fibrillation and prescribed Xarelto, 10 milligrams to prevent stroke. There's no history of AFib in his charts. His pulse is 52 and his blood pressure today is 135/80, and he's lost 5 pounds since he was last here 2 months ago. He's still taking his Lipitor for his cholesterol.
Rapid heartbeat. And this never happened to you before?
Well, it has. I just didn't tell anyone about it.
Dad, why didn't you tell me?
Well, it was such a small thing, I didn't want to worry you about it. And it stopped on its own, so I thought everything was okay.
I want to hear what happened both times. Let's start with what happened 2 nights ago.
Okay, so a couple nights ago, I got home from work.
Warm handoffs improve communication, encourage engagement and questions from patients and caregivers, allow patients to clarify or correct information, build relationships, provide a safety check. As you'll see next, Even a passing comment can lead to the identification of safety risks.
Amelia, do you have any information from the hospital?
I got the hospital to fax over the discharge summary, and Mr. Winston brought his discharge instructions in with him.
That's great.
Mr. Winston was seen by Dr. Ortiz, the attending cardiologist, at 10:15 on Tuesday nights. After Mr. Winston was diagnosed with atrial fibrillation, he was prescribed Xarelto 10 milligrams once a day, which Mr. Winston says he's filled today and has started taking.
That makes sense, but I was told 3 times a day, not once a day.
May I see the discharge summary, please? The blood thinner Dr. Ortiz prescribes is only taken once a day. The instructions from the cardiologist says you need blood work in 3 months. Maybe that's where things got mixed up. You take 1 pill once a day with your evening meal, and in 3 months you come back in for blood work, and we'll see how things are going.
That makes sense, but this thing is kind of confusing.
Just to be safe, I want to make sure we're all on the same page. Can you tell me how you're supposed to take these pills?
I take one of these pills, Xarelto, once a day at dinner time.
Yes.
Can he take it in the morning at breakfast?
No, this should be taken in the evening, and it's important to take it with food. Okay, now, let's take a look at you. Thank you, Amelia.
It's so nice seeing you both.
The warm handoff is a tool that primary care practices can use to better engage patients and families and to improve communication. This can lead to safer care, better patient understanding, and greater patient satisfaction.
Okay, so that was a great demonstration of the benefits of a warm handoff from the MA to the PCP. So referrals, as you know, the patient-centered referral management is one of the MDPCP requirements, and there are a number of referrals that can be made for the patient based on their healthcare needs to different specialists. So for some of your high-risk or chronically ill patients, you could have 4 to 5 referrals, and how we help our patients manage these referrals are very important. But we'll discuss more on referrals later on in the slide. Now let's do a quick refresher on longitudinal care management or long-term care management targeting your high-risk patients. They should focus on disease prevention, goals, intervention, and treatments. So first you want to identify your high-risk patients. Then you want to do outreach and enroll them into long-term care. Next, you complete a comprehensive care management assessment, and these are usually configured in your EMR. Then after the assessment, you establish a care plan and then implement the care plan, which outlines the problems, the goals, and the interventions. Finally, you want to make sure you continually evaluate your patients to ensure that the interventions that you have in place are contributing to improving the patient's health outcomes. And just to expand on the care plan, since this is one of the key requirements for managing your longitudinal patients, we have an example of an evidence-based guideline, and this is the AAFP tool. So this is a tool you can use to develop a care plan. So for an example, if you have a high-risk patient with diabetes who is at a level 5, if you take a look at level 5 that's located right here, the care plan should include things like patient education, self-management, home self-monitoring, fall risk management, and a referral to the CHW for links to community resources. As always, you want to make sure that you document care plans and follow-up care in your EMR. The next care management concept that I'd like to expand on for you guys in the second year program is the self-management support. So this is the care and encouragement provided to people with chronic conditions to help them understand their central role in managing their illness, helping them make informed decisions about their care, and helping them engage in healthy behaviors. So one tool that we can use to measure the patient's activation and their readiness level to participate in self-management support is the PAM survey. If you don't have access to the survey, during the assessment with the patient, you can assess for their willingness and their capability to take some responsibility with managing their conditions. Then you can add a self-management goal to their care plan. You also want to provide support with education about the patient's chronic illness through health coaching and referrals to support groups. And also, as always, you may need to help your patients secure DMEs and also recommend online tools and apps that can assist them with lifestyle changes. And, you know, apps such as the Apple Health app, MyFitnessPal, My Sugar Buddy, and so on. So here we have an example of what you can find in a patient's care management plan. So for our test patient, Ms. Anexa, we've identified a problem with medication management and compliance. So her first goal is a care management goal to receive medication education and counseling at her next office visit. We have the intervention as that the practice pharmacist will meet with Ms. Anexa at her next office visit. The outcome is Ms. Anexa will need ongoing medication follow-up to ensure she's compliant with her meds, and this will be an ongoing action. The self-management goal, which is goal number 2, is that Ms. Anexa will take her meds as prescribed every day for a week. The interventions that we're going to do with that is we're going to receive an electronic reminder medication pill box that will send a daily report to the care team. And the outcome for that intervention was that she took all her meds as prescribed for the week, and that goal was completed. So we have a 2-part poll question. So first we'll put up the first poll, review the results, and do the second poll. So the first poll, can we ask, where are you with providing longitudinal care management for at least 5% of your patients? Have you just started? Have you started, but it's a working progress, or is it already in place?
For the polls, if you haven't already, please select your answer by clicking on it on the screen. We'll give it about 10 more seconds for folks to vote. Right, we're going to close the poll now.
Okay, so thank you. So 53% have already have this in place, so that's awesome. So for those of you who are already providing longitudinal care management for at least 5% of your patients, you're well on your way to improving care delivery, especially for your high-risk patients and also their health outcomes. And for those practices who are just started or still working on progressing towards that, you should at least have some additional tips on how to advance in that area based on what we've just discussed. And again, you can feel free to reach out to your CTO or your practice coach to support you as needed. So we have our second poll. So with longitudinal care management, which of the following are you already implementing in your practice? Are you implementing care plans, self-management support, or both?
All right, if you haven't done so already, please select your answer by clicking on the button for which answer you want to answer with. All right, thank you all that participated and provided an answer.
Okay, thank you. So 70% are doing both, so that's awesome. We want to tell you great work. You're well on your way to improving long-term care for your high-risk patients and also their health outcomes. And for those who've only established either a care plan or self-management support, you should at least have some good tips on how to implement both based on what we've discussed. And again, please feel free to reach out to your CTO or practice coach to support you as needed. Okay, so just to recap what we've discussed, we revisited key activities that usually occur before, during, and after the patient's PCP visit, and changes during COVID-19, and key program requirements on using data to continuously improve the care delivery, the empowerment and continuity, risk stratification and leveraging CRISP data, team huddles, medication reconciliation and medication management, ECQMs, using data to continuously improve care delivery, annual wellness visits, behavioral health screenings, and longitudinal care management and care plans. And I'll go ahead and hand it over to Dr. Okeke to complete the rest of the session.
Thank you, Yayo. For the second part of the session, I will start with this illustration to remind us of the balancing act that occurs between long-term care management and short-term care management, because patients can move from one side to the other of the balance. So you can have a patient who's in longitudinal care management, who is now in need of an episodic care management support following a recent hospital discharge, for example. And on the other hand, you could have a patient who was previously stable, but after an episode will now require more long-term care management. What we know to be true is that if we can provide long-term care management, we can reduce, for high-risk patients, we can reduce avoidable hospitalizations and ED visits and the associated cost. And this is at the core of what the MDPC program is about. So because of that, we need to be more proactive about how we manage our patients, care coordination, and care management. So in this next slide, you get to see an example of a practical workflow on how this can be all tied together with short-term care management, long-term care management, and the day-to-day work in your practice. This is all. There's also a handout in your handout packet with this graphic so that you can look at it more closely because it's kind of tiny, so you cannot see very clearly. So in this first example, it's a simpler structure. And here on the left, you have care team roles that are identified. You have the PCP, the panel manager, lead care manager, the MA support care manager. You can also appreciate the handoffs in this view from one care team member to the other and the other. So for example, you can see the PCP referring a patient directly to the lead care manager for long-term care management, the panel manager also reviewing the ENS report, probably a MA or a CHW outreaching the patient and then escalating this to the lead care manager, and then the lead care manager outreaching and completing a care management assessment and determining the need of the patient and establishing a care management that documents what these needs are, making the appropriate referrals, and again, to members of the team like the medical assistants to schedule an appointment or to the CHW to actually support with addressing the patient's social needs. This other slide, again, is the same practical workflow, but this time there are more members in this particular care team. So just bear in mind that no matter what the situation is, we just talked about team-based care, make sure you tailor this to meet your needs based on your team-based care structure. Again, this is also in your handout, so if you need more close review of the graphic and see how you can look at this to give you an insight or framework of how you can come up with something similar or your own. Again, rely on your CTOs for those who have CTOs and your state PMOs practice coaches to support you with this. So just a quick overview of ECM here, and this will fold into other conversations about using data. So in the last session, Yayoh just went through longitudinal care management or long-term care management. You already know that episodic care management is a key requirement for your patient care delivery in the MDPCP program. So using the CRISP ENS report, which you all do already, to identify your patients that might need episodic care management, the other ways you could identify the patients, either you had a new diagnosis, the patient has a new diagnosis as determined by the PCP, or a life-changing event. Whatever the case may be, when you identify the patients, you start by outreaching them, and time is of the essence, because in the MDPCP program, you should be able to contact identified patients within 2 business days for recent hospital discharges and within 7 business days for recent ED discharges. Then you have to make sure you do a medrec, medication reconciliation, and schedule a PCP follow-up visit for further assessment and medication management. The care management team should continue with follow-up, monitoring the patient until they actually transition out of that episode into a more stable state or condition. So let's talk now about using data to plan care. So it is the crux of what you do. You need to be able to understand all the effort that has been put in the past year, all the work that has been put in since the second year of the program began. How are you doing, right? So you want to know that we already leverage so many CRISP tools, but it's also important to understand how to use the data or the reports that you see in CRISP with your EMR data, and see how you can put this together to help you drive change. So this is a quick overview of the key steps you should take in using data to plan care. So first, you need to identify the key measures for ECQM, utilization, patient experience, and so on. Then identify your data sources, CRISP, your EMR, and so on. Next, you want to develop a process for data collection and analysis, and then determine the cadence for your performance review. This is important and something I hold very dear, because as a provider, you do like to know that all the effort you're putting in does result into positive outcomes for your patient's care. So you want to think through how you decide to develop a schedule for patient chart and panel report review. And some of this you can choose to do on a weekly basis, some on a monthly basis, some on a semi-annual basis, and some maybe on an annual basis. So regardless of what it is that you decide to do, just make sure that every member of the care team is aware that this is how we review our performance over time, so that they can be part of the process and understanding how everything they do every single day makes a big difference. So now I'll just quickly go over a few features of the CRISP tool. Most of you are already familiar with that. Here is the care alerts. Again, this is a short description of critical information for your patient care that's generated for each of your MDPCP patients. Most of you already have a CRISP representative each practice, so please reach out to your practice representative to make sure you have this in place. Next is looking at the MDPC report. This is the landing page. It kind of gives you a summary of your patient population. But in the red box, I just wanted to turn your attention to three key reports and tools that you can do a deeper dive into that can help you best manage your patients, especially your high-risk patients. So first off is the utilization and cost, or PMPM trend. Yeah, you can look at this report and you can drill down the PMPM trend by claim type and provider category. Remember though that it's not a fair comparison to look at the average payment amount by physician or provider. That's not what this is about, but to kind of have an idea of an average claim payment amount for your practice and see how overall you are able to improve the utilization, honestly, that do drive these costs. Next, you want to keep using your CRISP PAH tool. The poll shows that a lot of you are already doing this to target your high risk and at-risk patients. The CRISP continues to improve the different tools that are available to you. Now also you do have the COVID susceptibility index for you to know your patients who are more at risk of contracting the virus, and you can be more proactive in how you support your patients and provide resources and coordinated care for them. One feature that I think is really cool about this is how you can export information from the CRISP platform. So you can now download this sheet for the pre-AH event reports, and at the end you can see over here in orange, it does also have the contacted follow-up guidance and status for you to just use that one sheet as an actionable tool to actually check the boxes and see what patients have been seen and what time you have to allocate to making sure you get this done. To learn more about the CRISP PH tool, there's so many webinars out there, but here are the links to get to those. And the last feature for the CRISP report that I wanted to make sure we touched on was the professional services report. And I think it's important to know how this leads into how you can get a care collaborative in place. So you can use this tool to sort of drill down and see which of the specialist physicians that you refer your or providers that you refer your patients to, and identify those high volume, high cost providers you refer your patients to, and see if you can sort of put a care collaborative in place, which is pretty much an agreement between your primary care practice and the specialist to make sure that patients have access and receive timely care. In this next slide, we just expand more about care collaboratives to give you a sense for what you can do with that information. So to establish a care collaborative agreement, after you've identified the specific providers you want to reach out to them, request a meeting, draft an agreement similar to what you see on the right-hand side here. So this is a sample that you can look at and use it and tailor it to your needs. The key thing to point out in this draft is that if you look, there's a left side and there's a right side. That's all agreements should have. What is the primary care, what are the primary care expectations? And what are the expectations on the specialty care side? Then schedule a meeting, meet with the specialist and review the document. Get feedback, updates the document, and you have it in place. You don't have to necessarily sign on the dotted line, but at least there's a more focused understanding of what this collaboration means. In this example, you can see that cuts across the transitions of care, access, care management, and also patient communication. Again, remember, if you think back to a couple of slides ago where we talked about the patient seeing all the care team members as a cohesive unit. This is another approach to make sure that our concept of team-based care and really advanced primary care is sort of embodying that whole concept with the patient in mind and making this very patient-centered as possible. So the next slide is just, again, to call out advanced care planning only because it is very timely to talk about this. Dr. Haft already mentioned this, and you can see the list here in the box below to go back and listen to those recordings. One thing I want to call out here for the practice staff, especially for the lead care manager, if you have patients on your LCM list, please do a chart review, check to see if they have an ACP in place. When you huddle with the provider, make sure you remind them if a patient does not have an ACP in place, as that's something that can be done in the next PCP visit. So that's the way we can help to keep promoting the ACP being completed for our patients, especially because they are Medicare and more senior patients. So as a recap for this session, we have taken the time to have practical conversations, shown you templates and discuss activities that cover episodic care management, following up with the ED and hospital discharges, using data to continuously improve care delivery, leveraging your CRIS tool, having alternative care visits, using data to plan for care and your patient population, care collaboratives, and advanced care planning. In session 5, we will do sort of like a demo of an interim measure of your day-to-day work and try to see how you can best leverage the data that you have at your disposal to understand where you are in your care transformation journey and what more that you could and need to do. So at this point, I would hand this off back to Angelica as we take another short break. Angelica?
Thank you, Yayo and Dr. OKK. So that concludes our session 3, and we do have a 5-minute break before we get started with the next session. But before we break, I wanted to announce a couple of reminders. So if you have any questions regarding the training content for sessions 1 through 3, please type them in the question box. And again, we'll address them at the end of session 5, any questions that you have regarding the content. our presenters will be available to answer those questions. For those that are still having issues with downloading the handouts, apologies for the inconvenience and that issue. Again, I want to remind you that the documents have been uploaded on Connect, so you can try downloading them there. But for those that don't have access to Connect, please send your email in the question box, and we'll get the materials to you via email. So that's all the reminders that I had. It's 2:57 right now, so let's take a 5-minute break, and we'll come back at around 3:03 or 3:04, and we'll begin with session 4.